Good afternoon, everybody. Thanks for joining us this afternoon. My name's Pritam, and I'm an Upper GI Fellow in Nottingham and part of the PQIP team. We're going to go into the surgery-specific breakout session this afternoon. The two main things we're trying to look at is how we can improve PQIP data and what we can use the data to answer. So I'm going to introduce the first two speakers, Matt Bedford, who's a colorectal surgeon from the West Midlands, and Jonathan Wilson, who is a consultant anaesthetist from York.
Well done, Aaron. Good talk.
Thank you very much, everybody. Nice to be here this afternoon. I think really, we were talking earlier, we haven't got a specific formalised format for this session, but what we're really keen to try and get from you guys here with a colorectal interest really is just some feedback, some ideas, some stories about some of your successes in interacting with PQIP over the last 12 to 18 months or so, whether that be positive, but also problems that you've had, that you've faced. We've obviously been talking about some of those over the courses of the day. And also some of that may well be from the anaesthetic side, but also we're very interested. One of the reasons I've become involved with the project is to try and improve and expand our engagement with the surgical community with this as well. So it would be great to hear back regarding that as well, both in terms of positives and negatives.
We'll just sort of kick off a little bit with just one of the ideas of something we've sort of done in York, not necessarily specifically with the PQIP data, but around the PQIP scenario with the intravenous iron. Colorectal cancer, as you know, is a disease that often presents with anemia, and something like 45–50% of our patients are technically anemic when they first present. And a few years ago, nobody was really doing much about it, which was quite interesting. And then we started getting into the intravenous iron scenario. And since our peri-op medicine service started in 2015, as James talked about this morning, we've been a little bit more aggressive about getting patients on intravenous iron, even though most of them, we've only been doing it within a week or 10 days of surgery, because we get to see them very late, sadly, despite the fact they've been on the books for many more weeks. And we've done a little review of that and comparing it to sort of historical control groups that you've already heard about, and found that those patients who were anemic and getting intravenous iron, even though we didn't have enough time to push their hemoglobin up to normal levels before surgery, received far fewer transfusions around the time of surgery, and particularly after surgery, compared with those patients who were anemic and for whatever reason didn't get intravenous iron. And they tended to have higher hemoglobins, that group. That's probably why they didn't get intravenous iron. Maybe they had a hemoglobin of 118 or something, and at least they said, oh, it's not worth doing, whatever. But they actually had more transfusions, even though they started surgery with a higher hemoglobin. And I think there was something, most of these patients' transfusions are not occurring in the time of, in theatre, because we're much better at doing it. They're occurring several days down the line on the ward. Patients are a bit peak and they're not doing terribly well. And the consultant surgeon usually says, or somebody says, oh, give them a bag of blood or something. And we haven't been very good actually at sticking to the 80 grams a litre rule as well. But I think by giving intravenous iron, we've demonstrated that we're getting patients on the right trajectory. So by that time, several days down the line, you know, the hemoglobin is recovering much better than those patients who didn't get the iron. And I think we're slowly starting to raise this awareness. And in considering it is a disease that, as I say, presents with anemia, and nearly half the patients are anemic, it's a bit surprising and probably a bit of a blot on us that we have taken so long to get hold of it. But anyway, that's a simple thing that we've been able to do, but we have had the advantage of using ourselves in the pre-assessment and the peri-operative medicine service to do that and to lead that. So it'd be interesting to hear about other people who've got the similar sort of experiences or struggled, and maybe share some sort of ideas about it.
Have we got anybody who'd like to start off with a question or a story?
Yeah, I think we are meant to be Slidoing, aren't we, I think?
We should have Slido on as well.
We'll have to do it manually on the phone here, if you're too wary of actually speaking.
The first thing that sort of struck me is when we talked about the patients earlier, informing patients and taking more responsibility of their care, it struck me remarkably about how we are now getting the information that we're responsible for. So this idea of you tell patients you need to exercise more or do more, take responsibility and expect them to go and do it. Thoughts about interesting juxtaposed for this anemia. We know that 70% of patients
I think it's you've got to, this is where it comes back to the context that people talked about earlier, that despite the fact we all work in this marvellous global or some national system, most trusts operate in very different ways. And we struggled with this at first. Then we found, first of all, that we have something called a medical elective suite, that's a couple of rooms in outpatients where patients could rock up and get the infusion, but by an appointment basis. So sometimes they could do it there and then, or sometimes they'd have to come back in a day or two. But then we found there's another, the medical, it's one of the medical assessment wards for acute medicine. They also do these iron infusions. We didn't know about this, but they will do them virtually there and then for us. If we see a patient in pre-assessment and we've looked at their HBs and it's low, and their colorectal surgery is next week, we can send them down and they'll get it done. But nobody was advertising it, nobody was shouting it from the rooftops. It just sort of happened by accident that we found out, and it's right at the other end of the hospital. But you know, look around in your hospitals, and you might have these odd little services that are running around that you can actually use, and you have to sort of build them into your own hospital-specific pathways.
So we did the same actually, but then we got banned from using it because it was getting so popular that people run their normal services. That's where the crisis points come, because everyone knows that the treatment should be given. There's a facility that is provided to a proportion of our population, but then once we did stop doing it, getting towards what we should be doing.
Well, that's where you've got to get your data. And I mean, if you're measuring it yourself or just on PQIP data or whatever, if you can show that it's making a difference, and involve your transfusion nurses as well, because they're very good at telling you all the transfusion data, what's happening on the wards. And once you can start, you know, demonstrating that it's maybe saving money, maybe reducing the length of stay, etc., then you just have to keep measuring it and banging on about it until somebody puts their hand in the pocket and rattles the change. Somebody.
I'd be interested in how people have got around it. It's similar sort of thing, silo approach to finances. So we've got a fabulous preoperative anemia clinic at Thomas's, but they want 6 weeks in order to correct the anemia, so they won't see the patients, the short notice patients. Our upper GI patients have got a really good multidisciplinary system, including seeing nutrition. My pre-op nurses do pre-op nutritional bloods in the upper GI patients. I've only just been approached by the lower GI ERP nurse to sort out nutrition and hence iron and so on. But all of this is going to involve investment in our clinics, which is run by theatres, anaesthesia and palliative medicine, and all the monetary gains in terms of length of stay are going to be gained by surgical directorates. And because we're all marked on our own finance sheet, try and get that across, and we just get a standard amount of money for reassessing any patient, regardless of whether they're ASA 1 or ASA 3 having complex major surgery. So has anybody had any ideas on how to get over that silo behaviour? Please tell me.
Do you want to contribute to that, or was that a different question? I think, again, context will vary. We've been fortunate enough to have, over the years, finance director in the trust who actually sees the thing as a global situation. And if we, like, for instance, coming back to the time when we all had to buy more cardiac output monitors in theatre and optimization and all that kind of stuff, and we demonstrated that we'd reduce length of stay and complication rates and all that kind of thing. And he saw that everybody in the whole trust benefited in terms of the cost. And certainly the way the CCG funds things now, it's easier for us to go along and say that if we do something in silo A, then silo B will benefit, but everybody benefits. But, you know, you've got to depend on having a decent and understanding guy at the top there. So.
I think as well, one of the things that PQIP, the way that we collect the data, could be potentially useful in this area as well, is obviously a lot of the work that's published at the moment regarding iron and impacts on, say, perioperative blood transfusion and things like that. PQIP are also measuring quality of life at 6 and 12 months, and there is some preliminary data out in the literature. I saw one of the Nottingham, and I've done a lot around intravenous iron and colorectal cancer resections, and they've got some data relatively recently published showing about impact on quality of life, you know, in 6 to 12 months. So hopefully some of what we're collecting as well could potentially help with that.
We've got time for one more little point.
So I just want to sort of pick up on these points about sort of dealing with finance directors and the CCGs. We've sort of done it around, so transfer of rehabilitation services has been extremely challenging in the financial environment we find ourselves in, Nottingham in particular, but that's replicated across the UK. So what we've actually done is gone to cash-rich partners. So we've gone to our local football team, and they've worked with Macmillan to provide a service where every single patient diagnosed with cancer in the Nottinghamshire region gets access to personal trainers as well as a gym. And we've managed to get our patients in there as soon as they've got a diagnosis. And while there are great benefits, as we know from exercise, you know, we talked about the time frames, etc., and whether there will be a real benefit. The real advantage of these is not so much the exercise they do, it's a sense of community they get. They're surrounded by people who are undergoing the same operations, they've had the same operations, they start to get an idea of what they're going to find and what they're going to experience. And that actually is more valuable to us from whether it's consenting, whether it's managing their expectations. But there are lots of these cash-rich partners around in every city. I heard of Liverpoolian accent. I'll be working with Liverpool to see if I can get some free tickets to some of the games, but you're probably an Everton fan, aren't you? But there are lots of these companies and organisations in your local vicinity that will be wanting to work with cancer patients and really provide some infrastructure back into the local hospital. So just go out there and see who there are. And like I said, Macmillan partly supported this. Notts County, which is one of the oldest football clubs in the league, have funded this, and they've funded it now for the last few years.
It's a shame they're not in the league anymore, isn't it?
Sorry?
Shame they're not in the league anymore. It is 3:20, actually. We're meant to be swapping over.
So you can have 5 more minutes if you want.
Yeah. I'm not sure. Is this somebody in this room put up this question? We can't get surgeons to engage, saying none of this data is useful for us, or we're collecting similar data ourselves, so duplication is pointless. These are quotes from surgeons. Is this from that? Somebody in this room put that up? Or are we picking up Slido from another area? Was that?
I'll speak as a surgeon.
Okay.
It's fascinating. We've had a conversation at lunchtime as to why can't we engage surgeons with this? Whose data is this? We've just had Matt here, and we've just had some fantastic discussions with trying to engage our surgeons in Geneva. There is still a very clear approach that the surgeons in our organisation will say it's an anaesthetic order. This is all anaesthetic. And I think that there's an element that Derek Alderson would really take on this for you. It's fantastic that he was here, but I think that the colleges, particularly the College of Surgeons, need to really push this to say that yes, we're very good at owning our outcome data, but as we all know, our outcomes are only as good as the teams around us. This work is fantastic at representing that teamwork. So I think that one of the things you can do as a surgeon is for the college to absolutely promote this, really overtly promote it.
So I personally think that, I disagree with Derek on this. I don't think we should be presenting our individual surgeon outcomes. I think we should be presenting unit outcomes. I've done 2 esophageectomies last week. Britton's done several cases. We're here. I've been on call for 4 days over in a different hospital. So the outcome of my patient is not dependent on the 4 hours I spent intraoperatively with them. It's about the entire team. It's about I need to just make sure they got it correct. It's about the intensivists and physios, the nurses on the ward, the junior doctors on the ward, and actually presenting unit data. You know, we hear that there are departments, unfortunately, out there that surgeons don't get on
on very well with implants. You present unit data and suddenly they will all become a lot more engaged in making sure that their unit does well. So I fundamentally disagree with Derek on that. And go back to the point about engagement. The way that I always try to sell this to my surgical colleagues, whether it's in my own hospital or other hospitals, is I ask them to go and tell me what proportion of your patients are still in pain at 6 months. Not one surgeon can give me that data, but using PQIP, I can tell you 50% of my patients still have pain from their thoracotomy at 6 months. That's something for essentially a palliative operation is not good enough if we're leaving patients in that much significant pain. And we use that data to work with RCCG to make them understand this as well. And they are in the process of thinking about whether to part fund our robotics program because we can make an impact potentially on long-term pain for them. So there are ways of engaging with this. It's about finding the right levers, I guess, when you're speaking to them. And that seems to work with some surgeons. It's not going to work with all of them, I don't believe.